All right. Hi, everybody. Welcome to today's Student-Led Journal Club seminar series. This is our first one of the spring 2023 semester. So without further ado, I will introduce our speaker and we'll get started. Student Dr. Nicholas Pettinelli is a second-year medical student at Kansas City University College of Osteopathic Medicine. Originally from New Britain, Connecticut, Nick graduated with a bachelor's in neuroscience from Trinity College in 2015, where he served as president and captain of the Rugby Football Club. After spending several years working in emergency medicine as an ER technician, he pursued a master's in Biomolecular Sciences from Central Connecticut State University in 2019. Nick enjoys spending his free time with his fiancée Laura and pets Barnabas and Ursa, weightlifting, and is an avid pickleball player. Currently, Nick is interested in exploring different surgery subspecialties, including orthopedic surgery, acute care surgery, and potentially returning to the trauma bay where his healthcare career began. So with that, the floor is yours, student Dr. Pettinelli.
All right. So hi, everyone. As stated, my name's Nick Pettinelli. I'm an OMS2 here at KCU in Kansas City, and I'm going to be presenting to you folks today about virtual reality and whether it's an effective tool for orthopedic surgery trainees learning techniques in arthroplasty. And this is a systematic review and meta-analysis. And I also want to just give a special thanks to everyone here today and the MSSU KCU Research Consortium for having me here, and Dr. Andrew Jimenez and the Jimenez research team for their mentorship and guidance on this project. So I just wanted to introduce myself and give a little information about me. This is my fiance and I, my fiance Laura and I, where we got engaged this past March in Cabo, Mexico. My buddy Eric and I, my de facto pickleball partner, we won a tournament up at Chicken and Pickle in KC and won these sweet backpack coolers. And then my pets, my dog Barnabas, who's also a pickleball fan, and my cat Ursa, who is actually has a polydactyly mutation, so he's got some pretty cool thumbs. So I just want to give a brief outline of today's presentation. So first, I'm going to introduce orthopedic surgery education as a whole and virtual reality as well, and then kind of introduce our hypothesis and how we went about conducting our systematic review. And then I'll kind of discuss our results and discussion and applications of that information, and also be willing to entertain any questions. So I'll get started by talking about current training tools in surgical education. And so current tools, obviously by far the best experience you can get is participating in and or observing surgeries. Now, next to that, if you can't get in the OR, cadaver preparation is largely considered the gold standard for surgical simulation. Next to that, you have sawbone simulators like that seen here, where residents and students can kind of work outside of the OR and best simulate surgery. And then after that, you're kind of limited to these more passive modalities such as technique guides or instructional videos. And so now that I've introduced current training tools in surgical education, I can introduce some obstacles to keeping with those modalities. And so time is certainly an obstacle to consider when using these modalities. Cadaver preparations, I think it varies pretty widely between institution, whether you have a cadaver lab and a full-on staff that is ready at a moment's notice to get you a simulated OR or a case to prepare. Just as an example, if I'm a resident and I want to see an arthroplasty or joint replacement case tomorrow, I may not have the appropriate instruments or cadaver preps on hand to see that in a limited amount of time. And so that'll come into play as I discuss VR later. There's also work hour restrictions that everyone's pretty much now aware of 80 hours a week. And when cases or cadavers are not available, as alluded to, you're kind of limited to more passive learning methods. So now I'm going to kind of introduce virtual reality. Virtual reality, or VR, in the sense that I'm discussing it today is usually with a head-mounted display, or HMD, and dual dual grip hand controllers. And it's basically allowing you a 360-degree immersive and interactive environment. Now, VR has so many clinical applications varying widely from pain management, rehabilitation, psychiatric therapy, and even adjuncts to anesthesia. And I just wanted to give you an idea from one of the included studies what this VR setup would look like. So you have the head-mounted display, the controllers, and then this is what they're seeing in real time and getting feedback on their hand movements, as well as every hand movement is essentially tracked and measured. And so now that I've introduced VR, I'd like to talk a little bit about VR in surgery as a whole. And so VR in surgery offers a low-risk learning environment, a consistent and reproducible mode of assessment. It can be on-demand use, so you're not waiting for a cadaver lab to be set up. You can use it right away as soon as the program loads. And it has performance metrics, as alluded to earlier, that can kind of track your hand movements and basically compare between usage. So if you were thinking of more like a longitudinal course, you can see whether you're improving or not with each successive use. And so a recent review by Mao et al. Essentially compared standard training to VR amongst all different kinds of surgical subspecialties, and found that surgical performance was enhanced, as was procedure times, and intraoperative errors were also reduced. So now I'd like a chance to talk to you about VR in orthopedics specifically. There's been quite a bit of research about VR in orthopedics, but most of it has been limited to arthroscopy or arthroscopy in particular. And so that's where the bulk of that information has been devoted. As VR technology has kind of improved, so has the available procedures that are included in the VR software. So some of you may be wondering, why arthroplasty? Like, why are we interested in learning about joint replacement in VR? And there is a vast amount of instrumentation and arthroplasty itself comes with its own inherent challenges for residents attempting to learn it. So it's, the vast amount of instrumentation, appropriate implants, movement efficiency required, and it requires quite a bit of familiarity with the different components and steps required. And so I include this photo here, not because I know what each of these instruments are, but only to say that it is quite a bit of instrumentation to familiarize yourself with in an orthopedic program. And as stated here on the slide, cadaver prep or that specific instrumentation may not always be available on an as-needed basis, depending on your institution. And so this kind of led us to hypothesize that VR training, given with what we know, VR training would demonstrate significant improvement in the development of arthroplasty-related skills, surgical skills. And so this leads me to introduce our search strategy of our systematic review. Now, we used a PICO format, which most of us may be familiar with, but PICO is an acronym used to formulate a research question. So it allows you to compartmentalize the population, intervention, comparison or control group, and outcomes you want to measure. So in our study, we wanted to look at surgical trainees undergoing virtual reality training and compare them to standard training. And we would be measuring outcomes of surgical performance. And so to give you an idea of how we searched, we used 3 major databases, PubMed, Cochrane, and Embase. And we essentially started with this flow chart. And our search from all 3 of these gave us 330 studies, where about almost 120 records were duplicates and automatically removed. And then we basically screened 213 of these based on whether their title or abstract was relevant. So with the remaining, once whittling that number down and eliminating 201 of these, we ended up with 12 full text articles for review. And so once we got to that 12 full text review stage, we then had to read and determine whether we wanted to include these articles based on the following inclusion or exclusion criteria. We wanted to make sure that we were considering orthopedic surgery residents, fellows, or medical students that were actually utilizing virtual reality as opposed to other incorrect modalities that we weren't quite interested in, like augmented reality or mobile applications. We also wanted to only include studies that actually reported outcomes related to surgical performance, specifically in arthroplasty, and of course, written in English. We eliminated any case reports or other reviews, book chapters, anything that didn't really fit like primary literature. And so we ultimately ended up with this number of 7 full texts to be included, or studies to be included in our systematic review. So now I'd like to talk a little bit about the demographics of these 7 included studies. This is a bit of a busy slide, so I apologize, but the highlights to take away are that we got 7 studies with a total population of 148 surgical trainees, with a pretty wide breadth of training from 4th-year medical students all the way through the 5 years of orthopedic surgery training up through those currently in fellowship training. Now, most of our studies consisted of a level 2 level of evidence, with just one falling into a level 3 level of evidence. And this one different study was because it was a pre-post cohort study in comparison to the other 6 of 7 that were randomized controlled trials. If you'll notice, 5 of the 7, or majority, consisted of a short intervention period of VR training. So most of them received most of these cohorts received like one-off sessions of VR training. 2 weeks or only 2 VR training sessions, 1 hour here, 1 session, 1 session. This top row was kind of unique because as a pre-post cohort study, they didn't have a control. And so essentially everyone in that cohort received VR training and then were basically tested on their respective task at the end of that 6 weeks after everyone received VR training. So something that I feel gives strength to our study in particular is that all 7 of these included studies concerned medical education. And so the MERSQI represents a validation tool. This is an acronym for the Medical Education Research Study Quality Instrument. And so between myself and another independent reviewer, we graded each of these included studies on the MERSQI scale. So the max score is out of 18, and all of our included studies achieved a score of greater than at least 11.5. You may be wondering what that means. And essentially, for research pertaining to medical education, a score of the benchmark is typically about 10 out of 18 for research to be accepted into a consortium or a presentation or conference. So now that I've kind of explained our study demographics, I'd like to talk a little bit about how these included studies were measuring surgical trainee performance. So there's incredibly high variability across the included studies. However, the most utilized form of surgical skill assessment was the procedure duration. And I'm actually just going to hop back to the previous slide because I just wanted to show the general design of each of these studies was VR training compared to traditional learning modalities that could include like traditional technique guides or conventional training, even video training. And the procedures that they were ultimately done were arthroplasty procedures on a cadaver preparation. So they would receive the training, and then at the end of the training period, they would complete a task on cadaver as specified here. So these were total hip replacements, unicompartmental knee arthroplasty, more hip replacements, and then even a glenoid exposure task, as well as a reverse shoulder arthroplasty or replacement. And so procedure duration was the most common of the surgical skill assessments measured in 5 of 7 studies, as was the objective structured assessment of technical skills, or OSATs, in 3 of 7 studies. That's not a great number, but as you'll kind of see, you're limited on what you can statistically analyze by how many studies include a particular scale or measurement. So for us, the cutoff number was three studies were needed in order to conduct statistical analysis. So some other measures that didn't weren't quite used in at least 3 studies were novel assessments made just for that study, task-specific checklists, number of errors, and even procedure-based assessment, which is analogous to OSATs, but used more so in the United Kingdom. So now that I've kind of chatted about surgical trainee performance, I'd like to show you some of our statistical analysis and introduce our forest plots. So this was a forest plot analysis of procedure duration in the 5 of 7 included studies that utilized it. And the best way to interpret a forest plot is that we can see a line of null effect here with anything to the left favoring immersive virtual reality versus the control. And so you can see kind of like the average of each procedure duration from each study kind of falling to the left of that line. And the horizontal line represents a 95% confidence interval. So we're kind of like sure that the actual result is somewhere within that band. Now, the main thing I want you to focus on is this diamond, which represents the aggregate of results. So essentially, this was saying that in VR trained versus control trained groups, the aggregate results in the diamond show that VR trained groups completed assigned tasks more quickly compared to the control. And this was statistically significant because of our p-value of 0.01. Now, in contrast to this, our OSAT score didn't fare as well. In the 3 of 7 studies that did use the OSATs, you can kind of see by this diamond of aggregate results that it kind of spans both the control and IVR. And so with a p-value of 0.56, we determined that there was no statistically significant difference in the OSAT scores of control versus VR trained surgical trainees. And so I'd like to just chat about these results a little bit. The procedure times and improvement in procedure times in VR trained individuals, we think is largely due to active learning, rehearsal and practice, and the building of what we know as muscle memory. So essentially the residents and students learning off of VR basically got a chance to rehearse their task more instead of the control group that was limited to more passive watching of the procedure. And so we think this is largely what allowed them to complete their assigned task more quickly. In terms of OSATs, it's really tough to say much about it other than there was no statistically significant difference. However, it kind of highlights an issue in this arena of VR and surgery, and that is that in terms of statistics, we can't compare apples to oranges. We need a universal and constant scale to kind of evaluate VR and whether it's effective on surgeries or even surgery simulation. And so Laura et al. Actually kind of evaluated and validated this precision score which is essentially a standardized measurement tool, which I think could be the future of VR and whether we really do determine if it has a place in orthopedic surgery programs. So I'd also just like to talk about current VR use in orthopedic programs within the United States. And so a 2015 study demonstrated that only about 9.8% of residency programs utilized VR for arthroscopic surgery. Now, because COVID has, understandably pushed us towards more virtual methods, I'm estimating that this number has increased since that time. However, as you can see back from our demographics table, this kind of explains the scarcity of multi-center studies. So some opponents to VR might be wondering, well, this has got to cost an arm and a leg. So the cost of VR really isn't that much to residency programs. The hardware itself costs about $400, with the brunt of the cost coming from software and licensing. That same study that I introduced by Laura et al. Actually did a cost effectiveness analysis that said VR was 34.1 times more cost effective than traditional training methods. And almost certainly OR time was factored into that equation. Now, we might be wondering, how should VR be implemented in an orthopedic residency program? Well, as an extreme example, in France, their residents are further limited by residency work hour restrictions to 40 hours in a week. And so Walburn et al. Used a VR simulator that is quite a bit different from the VR used here. But the major takeaway was that first-year residents received at least 10 hours of independent practice in a 6-month period. And they all demonstrated, or statistically, with statistical significance, demonstrated improved instrument handling and improved procedure times. And I kind of think or project that this is the direction that orthopedic residency programs should go in terms of VR, where it's an independent practice outside of a structured curriculum, where in a similar fashion, you're required to get a certain number of hours logged to help your practice in a certain period, such as 6 months. And with validation tools and measurements like the precision score alluded to earlier, residency programs could better measure and detect improvement within each of their residents. And so this study isn't really without its limitations. Of course, there's a lack of a standardized measurement tool that I've discussed. The majority of studies here have less than 25 participants and are single center. And this is just kind of an inherent challenge of orthopedic residency programs, because most are small, have 3 to 5 students or residents per year. And most were single center, just kind of highlighting the need for more multi-center collaboration and to increase the strength of this data. And so included studies also primarily trained with only 1 or 2 VR sessions. In order to kind of get that muscle memory and the practice and rehearsal build up, I think we would need more longitudinal studies that are multi-center in order to really get some great aggregate data on this. And with certainty say VR has a place within orthopedic surgery and arthroplasty as well. Oops. So in conclusion, VR training produces tangible reductions in procedure time in these arthroplasty trainees, and its usefulness as an adjunct on-demand learning tool cannot be understated. And we also highlight the need for more longitudinal, multi-center studies to determine if VR effectively improves skills, but also ultimately patient outcomes within the VR. And I'll show my literature cited and take on any questions.
Awesome. Great presentation, student Dr. Pettinelli. As you just said, if anyone has any questions, feel free to either raise your hand in Zoom, or if you can't talk right now, you can throw it in the chat and I'll read it out loud. Does anyone have any questions? Dr. Wolf?
Hey, thanks. I enjoyed that. My questions are probably on the bizarre end of the scale, like much of the stuff that I do, but I was curious what the VR actually shows. And so let me tell you a little bit as the basis for my question. So my uncle Eric had his knee replaced early on in the process. And I was just flabbergasted how he blew right straight through one. I mean, he actually had it at his house after he had it replaced with the second one. And this big hunk of metal and the Teflon bushings and all that stuff that had just disintegrated was fascinating to me. And so I've kind of been interested in this, and now it probably is 20 years ago that I went to in Nebraska at Exarban at Omaha. There used to be a place that tested reportedly all the artificial joints and stuff in the nation. And so I was absolutely fascinated by what they were looking at, like what the joints had to be made of and how hard they needed to be and things like that in order to maintain their function over time. So then the other thing that they showed there that was fascinating to me was they were talking about how challenging it can be that the bones aren't necessarily all shaped the same. And what they were doing was, if you those laser lines that would be used by carpenters, they were actually shining laser lines on these bones and using it to guide their cuts in order to get a better fit for their things. And so I was, question one comes with, what does virtual reality actually show? Does it show them where to make the optimum cuts based on what component they're planning on using? Question number two is somewhat related to that, and it's relevant given your DO training, and that is I was talking with a former colleague here, Jay Danto, years ago, and he was saying that people go in and they get their knee replaced, and what do? But they replace it, everything kind of at the same angle that it was at where it was giving him problems in the first place. And he was lamenting that oftentimes they should have had their things aligned properly first before they went in and did the experiment or did the replacement. So with that, I'll shut up, but thank you.
Dr. Wolf, I'm really glad you asked that question, because I think the answer I may come up with answers both. I'm just looking to get back to one of my slides here. So I think the way that VR can potentially address this problem is that, can't really see it in this photo, but in some of the diagrams I've seen of VR and the environment that's simulated, is there will often be kind of like a meter reading out of here. And one of the main measurements you can get is implant angle and position. And so I think they're striving for a certain angle of implant. Now, whether that is appropriate for each individualized patient, I am not sure if that's within the realm of capabilities on the software, unless it has to be, unless it can be kind of tinkered with by the testers to say, hey, we want, X angle of completion here. But I think that's my best guess there. I hope I answered your question.
Yeah, thanks. The other thing is that when people get joints replaced, you have people that come out of the experience and everything's perfect, and other people have no end of problems. And so I was wondering to what extent quality of outcomes is potentially examined in these things.
I think that's one of the big questions coming out of this, is we're not able to say just yet what the outcomes are for patients. I have seen from other research projects in the realm of orthopedics that everything they do is based on PROMs, or patient-reported outcome measures. So it's all about, I think the whole field is kind of led by patient satisfaction rates, their quality of life scores, and there's various scales to kind of assess their daily living and tasks they're having trouble with. So I think patient outcomes are essentially at the forefront of guiding this field. I just hope that VR can kind of catch up to being able to measure their effect on that and in the OR. Any other questions?
Nicholas, I thought your presentation was very good. Your slides are good quality, and you explained everything, I think, with very good clarity. My questions, I got about 3 of them, and I'd like to just get your take on some of these. Pertinent to 2015, and I'm not sure when VR came into existence, but having said that, you cited some data that implied there was since then there was about a 9% usage, or there had been at that time. Do you have a good feel for percent today of usage?
Not quite. I haven't been able to find any good data that kind of gives us a clear picture on that. Okay. I was just able to estimate, based on COVID and that kind of forcing our hand to go virtual, that it has increased.
Sure, it makes sense that it would go up. And then with the increasing comfortability and practice and, let's say, acquired muscle memory, with the repetition, you can do it over and over, that kind of stuff. Again, my question is, how do you assess the tactile sensation of the operator who is taking on the pathology? Is there that perception of too much pressure, too little pressure? How is that tactile sense assessed? You may know what to do, but it's how you do, with some gentleness or be more aggressive. How's that evaluated?
I couldn't agree more that haptic feedback is definitely a huge part of the equation. I believe that VR software, especially in those handheld devices, is coming a long way in terms of the haptic feedback it supplies. So it's giving you resistance in a certain plane and or maybe a vibratory sense. However, I don't think it's quite to where it needs to be to get close to the that close to the real thing. I think, participating in actual surgery still holds as the gold standard of what's going to be the mainstay of your training.
Absolutely. Okay. And then the last thing I would ask is, anytime you are operating, your victims are typically not the ideal patient. And then having said that, unless it's an acute trauma, then by accident, then they may be in pretty good shape. But with your frequency of involvement with pathology and orthopedics, you're going to be running into degenerative joint disease all day long, some osteoporotic disease, etc. Does this technique, this plateau of, this platform of VR usage, does it take that into account with examples? Or are you looking at, it's not a cadaver type of procedure, but is the pathology different when you go in, other than the structural pathology? Is the makeup of the bone different?
That is a great question, and one that I'm not sure I can answer completely. I think that might be within the realm of possibility from the software creators, but I have not seen it in my research.
Okay, that's a fair answer. Again, I want to say excellent job, well presented, and very informative. Thank you very much.
Thank you so much.
It looks like you also have one question in the chat. Someone wanted to know if they could have the citation for the lower article.
Oh, of course.
If you want to
Yes.
scan to your references slide. Or throw it in the chat, whatever you want to do. Any other questions, comments? Looks like we have a question from Eric Reese.
Yeah. Hey, Nick, can you go back to the page where you filtered through all the different studies?
Of course.
Thanks. Sorry, I kind of came in late. Okay, so I was wondering what, when you say you excluded those 200 for the title abstract review, what was your criteria for excluding them?
Sure. Good question. So the criteria were basically the same as the inclusion exclusion on this page. However, because it was in our title abstract screening, it was a lot quicker. So we were mostly looking for, well, I should start by saying we were using Covidence research software, which kind of is a smart software that allows you to kind of get through that process a little faster. So it'll essentially highlight keywords. And so, you know, in a moment's glance, you could tell with the highlighted buzzwords, like whether something was relevant or not. And we also kind of used this this Pico format to kind of keep us on track in terms of whether something was relevant.
Cool, thanks. Just curious.
Thank you.
If you don't mind, can you go back to the citations?
There are two
There's
floor articles there.
Awesome. Any other questions, comments? If not, I would like to reiterate what Dr. Johnson also said and say, well done, great presentation. It was really good during the practice run, but it was great this time. You did a really good job with the transitions and those transition sentences. Thank you everyone for being here today. And thank you so much, student Dr. Pettinelli, for your presentation.
Thanks, everyone.